I'll just present one case here of a fairly typical patient, and I'll ask you to just comment on your thoughts, if that's okay. So, pretty common presentation. 38-year-old man comes to the male fertility clinic, and it's not uncommon for them to be in their late 30s by the time they get to us. Anyway, there's a history, difficulty conceiving over the last 18 months. Fit and well otherwise. Doesn't take any medications. His wife is a bit younger. She's fit and well. No reproductive issues. And he's done 2 semen analyses now, both of which show Azoospermia. When you dig a bit deeper, he gives a history of having an operation or operations as a child, but he's not entirely sure what went on and at exactly what age. So you go and examine him, and he's got scars in both the inguinal regions. He's got a small testicle on the left, slightly larger one on the right, almost normal sized on the right. And on the right side, the epididymis is a bit, you can feel it. It's a little bit prominent and firm. You can't feel any varicocele, but you can feel both vasa are there and present in the scrotum. So the question really is, what do you think of the possibility? What do you think could be going on with this guy, and what tests would you like to do?
Yeah, his biggest risk factor is it sounds like he's had bilateral orchidopexys.
Yeah.
So one of the key factors here is, what age were they done? So the younger the patient is, the more chances you have that you're going to get some somatogenesis. Now, if they've had an orchidopexy quite late, it's likely that there'll be impaired somatogenesis. But also, the fact that he's had bilateral unsended testicles means that there's going to be an inherent problem in the testes to begin with. So that you go on to this testicular dysgenesis syndrome.
Yeah.
So I'd just work him up as a normal non-obstructive azoospermia. Do a karyotype, do a Y deletion, check his FSH, and then if you're going to do a hormone profile, check his testosterone and LH as well. So that would be the straightforward initial screen that you do.
Okay, so great, yes. So there could be a few things going on. So you've got his FSH back, and his back is slightly raised, or raised at 15. Testosterone's borderline, 9.6, measured in the morning. And then you've gone on and requested genetics as well. He's got a normal karyotype. There's no microdeletions. And of course, we didn't need to do a CF gene test because we could feel both the vasa there in the scrotum. So one of the possibilities, you've already mentioned it really, is that there's most likely working diagnosis here is a testicular failure because of the underlying problem of testicular maldescent. Are there any other potential possibilities that we keep our eyes open to?
I think it's unlikely. I think with a raised FSH, it's probably unlikely to be obstructive, even though he's had surgery. Keep an open mind, because obviously, having had bilateral orchidopexies, there can be damage to the vas, if they've been done a bit later.
Yeah.
But I think, with the history, with a raised FSH, you're going to be looking towards offering him a micro-TESE, bilateral micro-TESE.
Yeah.
Depending on his testosterone, you might want to optimize that as well. If it's very low, you could give him anti-estrogen just to optimize it prior to the surgery. But actually, he's heading towards a micro-TESE to see if he's got any areas of somatogenesis that you can harvest.
Yeah, okay. So yes, agree that definitely the most likely thing is he's got bilateral testicular failure. But with these complicated cases, just to bear in mind, occasionally you could have one problem one side, another problem on the other sometimes. So how would you counsel him? You started to mention TESE. So he's there, he's got azoospermia, he's got an FSH of 15, there's one small testicle, one's slightly better. How do you chat to him now?
I think, initially you need to see the age of the partner. Obviously, if they're in the fertile age range, then, they can go towards fertility treatment. Obviously, one testicle being smaller than the other, the normal volume one, like I said, might be an obstructive cause there, but I think it'd probably be unlikely just with the history of bilateral cryptorchidism. I'd probably counsel him on the fact that, look, we can have a scrotal exploration lined up for him. We can, at the time, you can normally tell when testicles obstructed because the epidermal tubes are quite dilated. You can form a vasogram to confirm, but if they're going to be obstructed in the inguinal canal, they're quite difficult to reverse because of the scarring, etc. So to get things going, what you can do is offer them a vasogram on the good side. You can explore the testicle. If there doesn't look to be any dilated tubules, then just perform a micro-TESE on the better volume testicle because you don't need to take that much tissue. At least it means it can harvest sperm and get through towards assisted reproduction. Do a vasogram and see if they are obstructed anywhere. If they are suitable for reconstruction, you could do that at a second sitting if they want to be explored and reconstructed. But otherwise, the main thing here is to try and obtain some sperm so they can start treatment.
Yeah. And what sort of odds would you give him then? Let's assume that he's not got any obstruction and this is all production problem. What sort of odds would you quote him?
Yeah, I mean, it's irrelevant what his FSH is. So there's no correlation between the FSH and prediction of whether you can get sperm. So you've got to just give him the data for all comers. So I'd say to him, look, you've got about a 55-60% chance that we might find an area of spermatogenesis that can be harvested and store the sperm for later ICSI. And then in terms of, success per cycle, it'll depend on his partner's factors and the age. But generally, you're looking at 25-28% success per cycle with regards to ICSI as well. So generally, with a negative, result on the genetics, that's probably what you'll be quoting for all comers.
What about donor sperm? Would you bring that in at this stage, or would you?
No, I don't actually. So I would do it as a cold cycle. So what I say to him is, look, let's just do it as a cold cycle. Let's just see if we've got any sperm, because it doesn't actually matter if you're going to use fresh or frozen tissue if they're going to go through ICSI. So you might as well do it as a two-stage. So there's no point stimulating the partner because we might not find any sperm. And then, because the chances are that we will probably find something, I think it's better just to say to them, look, let's try and see if we can father your own biological children. If you fail to find any sperm, then you can have the conversation about, look, your other option now is either donor sperm or adoption. Because, there are ethical dilemmas, there are religious dilemmas. So conversations are very difficult often. Yeah. And the advantage of, going through the surgery, see if you can harvest sperm, is that they will then know that they've done everything possible to try and, father their own biological child. And then it becomes a much easier conversation in terms of alternatives.
Yeah, I totally agree. I think a lot of these guys are even content with closure, really, even if the odds are low. They know they've done everything they can. And then, okay, so he's very keen to have a micro-TESE as soon as possible. Is there anything, any downsides that you would talk to him about?
Yeah, I mean, there's complications with every, operation that you do. So there's the usual, complications about, bleeding, wound infection. But the main one is obviously, worst case scenario, testicular loss, which can cause hypogonadism. We are taking tissue away. So that means that, you might induce temporary hypogonadism. So about 20% will drop their testosterone, the FSH will go up, but about 90% will recover back to their pre-treatment levels. So you don't need to worry too much, provided they started off with a normal testosterone. If he's got a borderline or a low testosterone, then you need to just warn him that, look, long-term, you might need to have testosterone replacement. We wouldn't give you that now because obviously they can become azoospermic. If they've got areas of spermatogenesis, you might lose those as well. So you would say to them, if you're symptomatic, we can give you an anti-estrogen, but later on we'll monitor your testosterone. If it stays low, then obviously we can give you a replacement. So that's just the worst case scenarios.
Yeah, brilliant. Brilliant, thank you very much. So I think that concludes the fertility session. I think we'll hand over to Pankaj, who's going to wrap up the morning or the day, I should say, and bring things to a conclusion.
So it's been an excellent session. So Roland, thanks a lot, Dr. Professor Asif Munir, amazing.